Our MHLDA collaborative has been quite some time in the making. We've been on quite a journey in the county, and we took a step that felt a brave step at the time, but it's probably the best step we've taken. But we've worked together in partnership across agencies. So we've had NHS providers, third sector, homelessness groups, mine, different charities really coming forward to work together with us. So we got into a room and just had a blank piece of paper and said, what do our priorities need to be? What would make a difference for people using and providing the services? And we got hundreds of people's thoughts, but everybody's voice was important. And that was then distilled down together in co-production. What were their outcomes going to be? How are we really going to measure them? Not by widgets and numbers, but actually how people experience them. But real collaboration is about having an equal voice. Hi everybody.
Hello.
Hi. How are you doing?
You did really well.
So it's absolutely critical that our programme and our members, our team, have the ability to support and work together to make a difference for our population, because the demands are so much higher than when we started this work.
We need to think about more than just how we collaborate. There are some other key enablers which are going to really help the collaborative programme meet its aims, and one of those is contractual enablers. It would be an integrated contract for an integrated care system, which brings all outcomes together under one outcomes framework, and then wrapping that in a contract that gives legitimacy to that framework, it gives monitoring to that framework. So the way our programme is organised is that there is 4 pillars of work. There is a population health and prevention pillar, an outcome-based pathways pillar, an acute and crisis care pillar, and a learning disabilities and autism transformation pillar. Within every pillar, within every level of our system, there is representation from patients, service users and carers. The idea of co-production runs like veins through the entire programme.
The reason why I wanted to be involved in the MHLDA is that I'm absolutely passionate about working with the people that I'm working with, and we all have the same values. And I think for me that's the key thing here. It's taken years, and I'm not going to lie, I'm not going to say it's been really easy all the way. The levels of work that have been put in to actually get us to where we are now is just invaluable. I think my hopes for the future are really around making sure that that journey is seamless, and that there are no speed bumps, and that when somebody needs help, they get help. And when somebody doesn't need help, we're able to step back and just be there for them if they need us.
All a collaborative actually is, in practice, is just a number of system partners and system stakeholders coming round a table and saying we all share a common goal here. We're not going to be able to do this by adjusting the edges of our services and adjusting the edges of our pathways. We need to become a collaborative and start working to adjust the gaps within our system as a whole. My hopes for the future are that we can be more intelligent, more prepared, more able to help our patients, service users and carers as humans rather than as an individual diagnosis or an individual presentation.
I don't see a way of developing and sustaining our communities without working together. So my hopes for the future are to see a real difference for people experiencing mental health or who live with a learning disability and autism. That as we move into the future, we become more of one, that our focus remains on getting really good outcomes and making a real difference in our population.